injection, 397 participants with macular edema associated with BRVO, monthly injection of 0.3 or 0.5 milligram comparing with SAM injection, and those who received 0.3 had mean gain of 16.6 letters, and 0.5 had 18.3 letters compared to SAM. So definitely ranibizumab is superior, it shows. Another is ranibizumab with SAM in CRVO patient. Comparison is the same, showing there is much improvement in mean vision, 12.7 in 0.3, 14.9 in 0.5 compared with 0.8 in SAM group. Another one is Copernicus, where there is a comparison between aflibercept SAM. Here, 188 participant with secondary macular edema secondary to CRVO were the participant, and it shows that the visual and anatomical improvements after fixed dosing up to 24. There is a PRN dosing from 24 to 52, like the dosing were reduced, needed less, with reduced monitoring frequency from weeks 52 to 100. So that is the longest one. Another one is Galileo, which is another landmark. There also there is a comparison between ILIA and the SAM. There like 60.2% receiving aflibercept gained more than 15 letters compared with 22.1% of the SAM group. Another latest one is the eco study report 2. Report 1 is for the diabetic retinopathy, and this is for the vein occlusion, which also shows that after here, like 3 different, they have taken both all central retinal vein occlusion, hemiretinal, as well as branch retinal vein occlusion, and they're compared with all 3. Bevacizumab, ranibizumab, and aflibercept, and they show that after each anti-VEGF injection from 1st to 16th, 60% of the patient achieved more than 20/40 or better, and also there is improvement in the central retinal thickness by spectral as well as time domain. This shows that all these studies show that this anti-VEGF is definitely the first line approach. And with the availability of fundus wide field angiogram, the art of reviving the interest, the laser therapies is also coming back. So this is mainly important for suppressing macular edema as well as also the neovascularization. However, we still sometimes need to consider corticosteroid. So this is the patient showing this recent onset central retinal vein occlusion in the with wide field angiogram showing many ischemic changes, with diffuse macular edema in the spectral domain as well as in the 3D. So this is before and after treatment. On the right side you can see this is the recent onset CRVO, showing there's improvement in retinal hemorrhage and dilated vessels on the left side in the top left. Also showing there is reperfusion also occurring, and in the third row there is even the diffuse leakage is also showing a resolution, and the final one is the OCT showing resolution of subretinal and subretinal fluid. So with all these, we can say that from results of BRAVO and CRUISE studies, as well as from the CRUISE trial, that is the ranibizumab has significant improvement for CRVO patients, and that can improve up to 50% without any side effects, especially as of steroid of intraocular pressure as well as cataract. ELI, the aflibercept, is already proven by Galileo in Europe and Copernicus in the United States. So, however, the overall results are very similar to that of the ranibizumab. Avastin or bevacizumab, there are no robust data as such because there is such small case series and retrospective. However, they seem to have similar results. So, which one to choose? There is no head-to-head prospective trial, so which one is the best remains still an open question. However, for the cheaper options, we can use Avastin, but especially for the younger RVO patients. However, we need to keep in mind that it can cause potential increased risk of contamination because of the compounding factors. However, we need to treat in the vein occlusion with macular edema, we need to treat aggressively and early, so that the level of VEGF is reduced and also prevents the worsening of non-perfusion. Sometimes there can be reperfusion, as we've seen from the previous picture. So we have to treat at the time of diagnosis which outweighs the risk of treating patients who may resolve spontaneously. So switching anti-VEGF agents, we can use, as there is a definite visual acuity benefit, we have to choose, like sometimes if there is no response from one anti-VEGF, then we have to switch to another one. And especially choose Avastin or Lucentis first, and in case of refractory cases, Eylea, when patient want to try to decrease the frequency of injections. As RVO is the multifactorial disease, both inflammatory and it has both inflammatory as well as vascular endothelial growth factor components. Sometimes anti-VEGF might not be enough, so then we might have to combine with steroid like Ozurdex, or laser can also help. So long-term management is also very important, especially in case of CRVO, as shown by the Horizon trial, that visual acuity declined in CRVO patients who weren't followed closely enough in the second year. So the long-term follow-up for these patients is also very important. So this is all. So with this, I would like to invite you for this Nepal Video Retina Conference, which is happening in September 25 to 27, along with Indo-China Ocular Inflammation the meeting in Kathmandu, Nepal. Thank you.
Dr. Pradhan, just for the information of our colleagues, how much is the average number of injections would we require in a VRVO?
It is about 7 to 9 injections in a year, in the first year, and then decreases afterwards.
So we must follow up all our BRVOs for 1 to 2 years minimum?
Yes.
And you must tell them that 5 to 7 injections will be required.